And the health service does need serious reform. That reform, as I've just said, should be steady, purposeful, with a clear direction, and avoiding unnecessary upheaval. Changes in lifestyle, in technology, in medicine itself, and in the expectation that people themselves have of the services they receive, all of this means that we need a more decentralised, a more patient-centred, and a less bureaucratic system. And at the same time, we have to be frank about this, those of us who support the NHS, if we are to maintain public consent for all the extra spending that the NHS receives, we have got to ensure better value for money than we've had in the past. But my point today is this, that reform should be bottom-up, not top-down, wherever possible, driven by the discretion of professionals responding to the needs and wishes of their patients. We want to change, if you like, the essential power relationship in the NHS, from the current one, which is a vertical relationship where professionals are told what to do by the politicians and the managers above them, with patients just left to sort of take what they're given. We want to change that into a horizontal relationship where professionals have the necessary autonomy and discretion to respond to the demands of patients, and it's patients who are in the driving seat because they've got the ultimate power, the power to choose the service they want. So let me set out how I think general practice should work. I have a very simple starting point. GPs should manage the entire relationship that a patient has with the NHS, that dreaded word, the patient pathway, which I promised I wouldn't use. That means they should be responsible for providing the care that patients need, or commissioning it from other providers, or a mixture of the two. In a nutshell, GPs should control the budgets that NHS patients are entitled to. There is a good economic rationale for this. Budget holding, I believe, is the natural guarantee of efficiency, ensuring that money follows the patient and that it's spent on frontline care rather than on bureaucracy. GPs, rather than sort of remote managers, should be responsible for reconciling the available resources with clinical priorities and patient choice. And there's a good health rationale for GP budget holding too, what's called the continuity of care. The family doctor service is the way to ensure that even though patients may see many different specialists, there's always one doctor in charge, and that's the doctor closest to the patient, that's your GP. This is especially important when it comes to preventative action or the management of chronic conditions which require significant patient involvement. The plan for a national network of polyclinics is the biggest upheaval in primary care since the creation of the NHS, or even since the beginning of modern general practice in the 19th century. Because, of course, in 1948, GPs were effectively left alone as small independent practices operating under contract to the NHS. 60 years later, Gordon Brown is attempting to do what Nye Bevan never did, which is to nationalise the GP surgery, to make GPs salaried employees of the state and abolish those small practices in favour of large multi-purpose centres. Now let me in fairness acknowledge the government's rationale for polyclinics. I accept the scheme is not simply designed to save money. And as I said in my party conference speech last year, it's often a very good thing for GPs to share premises with specialists like physios, like pharmacists, and others. In fact, many GP surgeries already provide these services, and they're especially popular with young professionals. If you've got a back problem and say you need some jabs for a business trip to India, a polyclinic open till 8 in the evening may be just what you need. But frankly, that's not the sort of person who most relies on primary care. The government says that in London, most patients will be within 1.5 miles of a polyclinic. The people who need GPs the most, though, are the elderly, those with small children and those with long-term conditions. These are the people least able to get to a polyclinic and least comfortable in a large impersonal institution. They like to rely on the doctor they know at the end of the street, often in a building not much bigger than a house, and they've got a human relationship with that individual GP that they simply won't have with a member of staff at a polyclinic. So I don't object to polyclinics in principle, but I do object to the principle of imposing them on local communities without public support and against the wishes of GPs themselves. Where they occur, They should occur naturally, bottom-up change, as the voluntary combination of free agents, not as the latest structural reorganisation of the NHS. Lord Darzai, the health minister behind the polyclinics plan, has admitted that doctors will effectively be forced into polyclinics using the GP's contract. That, I believe, is quite wrong. So in conclusion, let me set out the 4 basic steps that a Conservative government will take. First, on funding, our commitment to a fully funded health service, increased NHS spending year on year. Second, devolution of power to the front line, especially meaning GPs, more power and responsibility for NHS professionals, and more choice and freedom for patients. Third, independence for the NHS as a whole. Politicians should be focusing on the health outcomes that the NHS achieves in exchange for taxpayers' money, not trying to micromanage every decision and every process. So we will formally make the NHS independent of government control. And then fourth, the conclusion of these reforms is a transformation of the Department of Health itself, from the National Manager of Primary and Acute Care to the agency responsible for public health. Those are the steps that we intend to take. Those are the things that the next Conservative government will take to reform and to improve and to safeguard Britain's National Health Service. Thank you very much for listening.